We'll be looking at two flavours of motor vehicle accidents today. Obviously, there's going to be more variety, but these are possibly the two biggest groupings that you're going to see. Acute. That is acute in terms of chronology. This is a recent accident, say within the first 4 to 8 weeks after the accident, and also severe, and then chronic. That is chronic in terms of recency. This is something that's been ongoing or episodic since the accident, could be years actually afterwards, and also in terms of severity, these are the less severe ones. We'll be looking at two flavours of motor vehicle accidents today. Obviously, there's going to be more variety, but these are possibly the two biggest groupings that you're going to see. Acute. That is acute in terms of chronology. This is a recent accident, say within the first 4 to 8 weeks after the accident, and also severe, and then chronic. That is chronic in terms of recency. This is something that's been ongoing or episodic since the accident, could be years actually afterwards, and also in terms of severity, these are the less severe ones. Clearly, the acute MVA is potentially more dangerous than the chronic one. It's reasonable to suspect that the chronic MVA patient is probably out of the danger zone. He or she has survived months or even years since the accident, and the same can't be said for the acute case. This could be undetected fractures, unlooked for fractures. They may not have seen the physician before coming to see you. They may have seen the physician at an x-ray and the x-ray has been negative, but it's been a false negative. Not entirely unheard of. There are hidden problems with neurological problems, brain damage, neurovascular problems and so on. So clearly the acute MVA is the one that is the most at risk from your treatments and your care. The other problem with a motor vehicle accident is that the thing can be so acute that trying to determine exactly what the problem is going to be near on impossible on a clinical exam. The best you can do is try to eliminate the severe problems, preferably through symptoms rather than tests, but eliminate the severe problems and let the inflammatory responses decrease, and then you may be able to find out what the problem is. It's very unlikely that clinical examination will tell you the difference between a rim lesion where there's actually a tear in the bone or the disc or the end plate and a serious post-traumatic arthritis or a fracture. So you're almost certainly not going to be able to say this is the problem, but you should be able to say with some degree of certainty, this could be the problem and it needs more than I can do in the clinic, and so refer it out. So this is where we'll be on this particular presentation, trying to sort out the more severe injuries from the less severe injuries that you can keep in your clinic. Also remember that because it's been to the ER, because it's been x-rayed, it does not mean that there can't be a fracture there. And a fracture is going to be the most obvious of problems compared to some of the other stuff that's present. So I said there were two flavours we're going to be looking at, and there is also an almost infinite variety of variabilities in these motor vehicle accidents. So let me define what the patient I'm generally talking about. This is within 8 weeks of the car accident. There is severe pain. It's generally speaking all over the neck rather than one little local area. If it is in one local area, then you're probably looking at a healthy tissue disruption, either a ligament tear or a smaller fracture. But generally speaking, it's either totally on one side of the neck up and down it, or it's on both sides of the neck, and they've probably got a headache as well. There's severe motion loss. Now, when I say severe, there's a cutoff point here, is if they've got less than 45 degrees The Nexus LRC, the American version of the X-ray protocol, says that they should be X-rayed. If they haven't been X-rayed, that should be enough for you to start worrying about getting one done. But when I say severe, I mean they've lost 50% of their range without too much trouble at all. And there is obligate functional loss. They can't go to work, they can't work full time, they can do some stuff, but they can't do the stuff they normally do, that type of thing. So what you've got here is a very acute patient. Now, I've said 0 to 8 weeks. If this is going on acutely like this after about 8 weeks and there's no real sign of improvement, this patient is actually complying with the need to rest, because this is what you do with an acute case. You let it rest. So if rest isn't making this better, then this needs probably more than you can give and more than you should be trying to give. This needs proper imaging. They need MRIs, CT scans, just to make sure there isn't a fracture in there somewhere, or one of the other injuries like rim lesions and so on, or jump facets. So this is the patient we're talking about now. Okay, so some of the conditions that may be laying in wait for you under the mess that is this patient's neck include fractures, both minor and major fractures. And the major fractures in the upper cervical spine can be life-threatening. Traumatic brain injuries, which includes the current buzzword concussion, but there are worse out there, including lacerations and bruising. Neurovascular injuries, disc herniations and the disc in the cervical spine, when it herniates in the upper part of the neck, and it goes straight back into the spinal canal. So if the patient has a congenitally small canal, then their risk from this disc herniation is much more than if it's a normal size, or if it's stenotic. Jump facets, which is actually a dislocation of the facet, it can come up and over that way and sit right in front. That could be unilateral or bilateral, and that can create all sorts of problems. Some percentage of which, not the large percentage, but some percentage of which also includes spinal cord compression. It's the ones that don't cause this that are likely to walk into your clinic. Rim lesions, which are tears, actual tears, through the bone, through the end plate, or through the disc, or a combination of them. And these are going to be acutely painful for quite some time. Craniovertebral ligament tears. The alar ligament is the one that gets torn. The transverse ligament, I believe, hasn't been shown to tear with motor vehicle accidents or with trauma of other kinds. If it does, it doesn't tear so much as it avulses from the bone. But fractures are the biggest cause of instabilities in this region, fractured dens in particular. And it's worth noting that fractured dens are missed on 30% of x-rays taken for a motor vehicle accident. It's the most commonly missed spinal fracture, apparently. Other ligament tears, not as common, if none of them are really common, apart from the alar ligament, but they're not terribly common. Muscle tears are not particularly common neither. If they do tear, if this is a rear end collision, which is the biggest issue here, rear end collisions will tend to tear the anterior musculature rather than the posterior musculature. So sternomastoid is at risk, but so is longus colli. Traumatic arthritis, which can be unilateral, but it will, because the pain can be so intense, can give you bilateral pain, but it's often bilateral. And then biomechanical dysfunctions. So these are all the things that can be laying in wait. And as I said to you, trying to sort this out can be difficult because the neck is so acute that it's difficult to come to any sort of specific diagnosis or specific test. So what we need to do is, from the subjective exam, try to rule out the more dangerous stuff, and that's what this presentation will be mostly about. So fractures, what you can see here in the top left, top right and bottom right are dense fractures. Well, I can't see the bottom right one. The two upper ones are CT scans. So the dense fracture actually shows on those quite clearly, but on the x-ray, I can't see it. I know there's one there because the caption said it was there, but I failed to see it. Now, if I can't see it, it doesn't mean it can't be seen, obviously. So whether a radiologist will see it or not is another issue. But this is about 15% of all cervical fractures, and I believe it's the most commonly missed spinal fracture going, and that they pick these up later on when neurological symptoms start to come on. So these are missed. So that would mean that would mean about 4.5%, I suppose, if my maths are correct, of all dense fractures are going to be missed, which is a significant number. Hopefully they'll be picked up because the X-ray was negative, but all the signs and symptoms were positive, and they would then do a CT scan. But I think CT scan there is the imaging of choice, in which case you're not going to need it. The other problem with X-rays is that this is an undisplaced fracture. Clearly, if it wasn't, we'd be in trouble, or the patient would be, and we wouldn't see them. But an undisplaced fracture needs to resorb some of that calcium in the area before the fracture can show. Also, the teeth need to be out of the way, so if the patient is unable to extend their head with an open mouth, then it may not be seen. The bottom left picture is a teardrop fracture. These are hyperextension fracture where it's avulsed by the anterior longitudinal ligament, and I believe the upper one, when they're on the upper end of it, can actually be caused by hyperflexion, where the top one comes down and just knocks it off. But I think mostly these are hyperextension fractures. These are disc herniations. As I said, the posterolateral disc herniations rarely occur even in the lower cervical spine, but when they do, they tend to be this low because the uncinate processes are not as well developed as they are in the upper spine. So from about C4 upwards, they're extremely rare. Disc herniations hitting the nerve root or spinal nerve are very, very rare. They get directed back by the uncinate process into the spinal canal. And as I said, basically depends on the size of the herniation, but also on the size of the spinal canal. There's usually a fair amount of room in there, so the canal isn't compromised enough for the cord to get compressed. And if the cord does get compressed, often there is no damage to the cord. Now, in the left-hand corner, this actually causes Brown-Sequard syndrome. So clearly there was myelopathy there. And the other one, though, there's no evidence that I can see. Maybe a little bit of whitening on the spinal cord, but this one may well not be a myelopathy. Anyway, these do occur, and they can produce myelopathy, although with our patients, it's not likely that we would see them, but signs and symptoms often come on first. And if you look at the study done by Sung, spinal cord compression can be asymptomatic, but still show evidence in the form of signs. Notably, the Hoffman's test will show these things up. These are images of jumped facets, dislocated facets, and the top picture here is showing the progression. So what you can see is that far left one is that it's ready to go, so it's sort of angled forward and it's just stuck a little bit there, and it's not fully dislocated, so the facets are covered. The second one is called a perch facet, where it just sits on top and it hasn't quite gone over, and the other one is a complete one where it does that over the top. So this is a hyperflexion injury. They'll come up and over. The right one is a X-ray, and this is actually showing it fairly well. It's anterior, although it could just be diagnosed as a partial spondylolisthesis degenerative, but there is actually, I think you can just about make it out there, but these are not very clear. The X-ray of this may not be very clear, it may not show it at all, at least not without a lot of looking. And the middle one is actually showing probably a reasonably severe one, and only about 25% of these apparently actually cause a myelopathy. And these can be unilateral or bilateral, and the bilateral are the more significant ones, and the bilaterals often need surgical relocation, whereas unilateral ones can be done under an anaesthetic. But this could walk into your clinic. I had a friend of mine who actually had one of these come in, and she saw it for 3 months, did everything she could think of doing, sending him back with the doctor sent him back again, X-rays were negative, and this went on for 3 months. She put a collar in, took the collar off, treated him with exercises that made it worse. Everything seemed to either make no difference or make it worse. And eventually somebody thought about doing a CT scan, and it was a jump facet. So they can come into your clinic. Whether you probably can't diagnose these as a specific jump facet, but this is going to show up as something very acute, and it isn't going to get better in that 8 weeks we were talking about earlier. These depict a rim lesion. This is a tear through the disc, the end plate, or the bone, the adjacent bone. And they're almost, in the cervical spine, they're almost exclusively caused by motor vehicle accidents. They're almost impossible to pick up on imaging. As far as I know, the MRIs don't show them at all well, neither do CT scans. And their significance as a clinical entity is still under discussion, although it's difficult to see how they can't be clinically significant when this happens. Okay, so this is those conditions with an immediate onset of severe pain, which have pretty much been all the ones that I showed you on with images of. So fractures, these will always have a sudden onset of severe pain. And when I say severe pain, I mean it's the severest pain the patient experiences with this generally. So that will be the worst of pain. It's within an hour or two of the accident, allowing for mediation effects to take place. So recognising a fracture, first off, it breaches the Canadian C-spine rules or the Nexus LRC. Now, we discussed these two protocols before. The C-spine rules is fairly immediate. It's much more applicable to us. We don't have to worry about things like intoxication, distracting injuries, and so on. If no X-ray has been done, it should be done, and it should probably go to the emergency room because you have no idea how bad this is or isn't. If the X-rays have been done, it doesn't mean to say they don't have a fracture. It means they're unlikely to have a fracture. So you want to proceed with caution. If you're still not really sure about this, I would still send it to the ER and ask them if they would do a CT scan, or get a second opinion from somebody there. But I wouldn't mess with this too much without eliminating fractures and finding something else. But it's going to be really difficult for you to do. High cervical fractures, sudden onset of upper neck pain, almost always a headache, almost always torticollis. So a sudden onset of torticollis post-trauma is an indication of a fracture all by itself, or a dislocation, something like an ARF, which we are not really talking about here. But an atlantoaxial rotary fixation can do the same thing. These will all look the same. That is sudden onset, severe pain, and torticollis. Also, there's going to be posterior midline tenderness. Don't palpate for tenderness unless you're really not sure what's going on. The problem with palpating for tenderness is if you find it and the patient suddenly jerks away from you, then that fracture may become displaced. It's not worth doing. So I've got it there because it is one of the signs of it, but don't do it if you've got the other three signs in place. Other fractures are going to be lower down. These can be subchondral fractures, which are fairly small, laminar fractures, transverse process fractures, which in itself isn't too terrible. The issue with them is, though, that they can damage the vertebral artery. So all of this would suggest a visit to the ER is in order. Rim lesions and jump facets. We'll look at we've looked at these. These are going to look just like a fracture. So again, they go to the ER because you can't tell the difference between them. Neurovascular damage. First off, an intracranial bleed. You're going to look for progressive headaches. And if you don't pick that up quickly enough, then there'll be cognitive problems and then motor problems, and the patient will stroke. So you want to catch it much earlier than that. Progressive headaches all by itself is enough to refer to the ER. When I say progressive, it's getting worse after a couple of days. Also, this headache is likely to be dissociated from the neck pain. It may be in the front, well, they've got no pain coming over the top. It may just be in the back and they've got lower cervical pain. but it's going to be topographically separated from the neck pain. Usually, hopefully, that you'll pick it up, but it's also going to be gravity dependent. So when they lay with that side down, the pressure against it is going to be painful. Or if it's in the frontal lobe, if they bend over to do their shoes over or bend over to do anything, that's when they'll feel the headache. Get it out as soon as you recognise it. Don't mess with this at all. If you're too unsure, send it out. All right, don't wait for it to get worse, because they can get worse very quickly. The other thing with these is they tend to be elder people, and there's usually a reasonably high impact velocity, sort of a delta of 60 miles an hour or so, but two cars coming together at 30 is that, a delta of 60. Carotid artery injuries, they're going to feel pain in the anterolateral neck. So your confusion is with the sternomastoid tear or the artery. The artery may show no neurological signs and symptoms. What you do is you palpate the muscle. Now, when you palpate the muscle, don't press into it, pinch it, so you've got no risk of going into the artery and possibly releasing an embolus. So pinch it. If that's not tender, get it to the emergency room. You could also look for evidence of Horner's syndrome with this, and this pain is enough to get them out of there. Okay, now muscle tears are the ones that you don't have to worry about. Sudden onset of severe pain, and you're going to find tenderness over that torn muscle. This is usually longus colli or sternomastoid, so you need to be able to palpate both, and the contractile test will be positive. So stretching it and contracting it are both going to be positive. So apart from muscle tear, pretty much anything with a sudden onset of severe pain that isn't evidence in a muscle tear should be enough to get you to fire it to the emergency room, or at the very least back to the physician. And finally, there is traumatic arthritis and biomechanical dysfunctions. Now, the biomechanical dysfunctions are around like everything else. Whether or not you examine them for them is up to you, but the thing is, you have to consider what you can do about them and whether or not you should be doing anything about them until you've got the inflammatory processes out of the way. So assuming this isn't something you want to send back to the ER or the physician, then the biomechanical dysfunctions are still a secondary issue. You've got to get rid of the pain. The pain will cause muscle changes, reflex inhibition, pain inhibition, segmental facilitation, weakness, and so on. It will cause changes in the muscle, and this is what you want to stop. Also, you're going to create more habitual fear in the patient because of the onset of pain. So the biomechanical dysfunctions are the least important of the lot, because they're not going to be moving the neck very much here at all. So although you may be able to find them, the question is, do you really need to? Because what are you going to do about it? These will come to light after things have settled down, and this is when you can do something with them. Traumatic arthritis is going to show up as usually a fairly diffuse pain. It can be severe, but it's spread over a larger area of the neck than the biomechanical dysfunction itself does. So this could be unilateral or bilateral, and you're going to find all the movements are going to be affected, and your job there is to settle it down. It's like any arthritis. If this was a swollen knee, you wouldn't have them running on it, you'd have them rest it. There is evidence for using collars with these people. I know that it's not politically correct, but there is good evidence that they make a big difference. You wear them for a month after the accident, and it makes a huge difference to the recovery of the patient. So these last two are the least important of these. And remember that the traumatic arthritis is going to overlay a fracture as well, but the fracture and the tears are going to show up because of the immediacy of the severe pain, whereas the severity of the traumatic arthritis will be delayed more than a few hours. So it'll be there. It may be there at the time, but it's going to get worse over time, and probably by the next morning it's going to be nearing its peak. Okay, so this is your acute pain patient. Most of it, your treatment is going to be aimed at reducing the pain, reducing the inflammation, and making sure that you refer the patients that need to be referred elsewhere out in a timely fashion.